I'm Bob Wells. I'm the Director of the Australian Primary Healthcare Research Institute, which is based here at the ANU. And I welcome you to our presentation this afternoon from Professor Chris van Weel. Chris has studied medicine at Leiden Medical School in the Netherlands and entered general practice in 1973. He's been Professor and Head of Department of General Practice, University Medical Centre, Nijmegen, is that right? Nijmegen? Netherlands since 1985 and 1987 respectively. Chris has quite long links with Australia and quite strong links. He's actively involved in local and international research initiatives. He was President of the World Organisation of Family Doctors, which has the lovely acronym of Wonca, from 2007 to 2010, and President of Wonca-Europe from 1998 to 2001. He was co-founder of the Brisbane Initiative, an international collaboration to help develop leadership capacities in primary care researchers. Chris is a renowned researcher and renowned internationally, so we warmly welcome Chris to give us his lecture tonight. Thank you, Chris.
Yeah, Bob, thank you very much for the invitation of speaking today and sharing with you a couple of thoughts on the issue of the effectiveness of primary care. And I will, if I get to, that's better, to that, explain a bit further on why I choose that topic. What I would like to go through is share initially a couple of what you may call well-known facts about primary care that I don't think the larger world has really appreciated as much as it should be. Then go into the evidence of effectiveness of healthcare and what that takes, and then come to the core of my theme, which is focused on the question: what exactly makes primary care such a strong contributor to effectiveness of healthcare? And from that, I would like to go into some considerations about what sort of academy do we really need if the points I'm making are correct. And I think it's important that you realize I'm not trying to pose primary care against secondary care, specialists against generalists. My thoughts are on the complementary or additional contributions of primary care in the larger framework of healthcare. So a couple of points that I think are fairly well known. First, the ecology of medical care, which has been in fact reported for the first time in 1961, and that's quite some time ago, which analyzes the flow of people through the healthcare system from a community or population basis, and tells us that in every community there are people who have quite frequently signs, symptoms, don't feel well, feel sick, whatever, and of course that is the recruiting ground for professional healthcare. People may consider whether it's a good thing to do consulting a doctor. In the end, it's only a small part of it, and I don't think medicine is actually realizing how small a part professional healthcare has in population ill health. And if they do, they consult a doctor quite close to where they live, and that's what we call primary care, and the hospital setting is much further away and much smaller in its actual reach. Now, what I think past decade the world has started to realize is that the morbidity spectrum in primary care is different from that in hospitals, and that's an important understanding of primary care, but it's only understanding part of it, and what will come through in my further presentation is a couple of other issues. For example, the fact that because of the link to the vicinity where people live and work, primary care has this strong orientation on the actual population or neighborhood or community, whatever you like to call it. And communities differ, populations differ, and as a consequence primary care differs within countries and around the world. The population perspective. The fact that primary care is dealing with the few people who come, while at the same time so many more with probably the same health problems will not contact the doctor. Why do they come? Was their personal aspect, their personal perception, needs, etc. And of course, and that is, I think, the world is waking up to primary care as an important factor in navigating health resources. Another fact that I think is well known but poorly appreciated is the fact of comorbidity. Has been reported, I think, consistently in primary care since the 1980s. If you really look into the primary care literature, you'll say that people like Ian McWhinney or Frans Huygen in fact built their work on the assumption that people have more than one health problem at the same time. In fact, medicine is only recently starting to appreciate this factor that is coloring primary care for a long time. All the people with chronic morbidity, the majority have 2, 3 or more health problems at the same time, and that is in fact influencing the possibilities of management of patients substantially. So for a long time we have described the virtues, the values of primary care, family medicine, general practice, as a medical generalist who's there for all health problems, all stages, all individuals, according to the needs of the patient consulting them, community-oriented, particularly with a focus on household, family, social determinants of health, a personal family, personal doctor, providing continuity of care, integrated care. A couple of years ago, Wonca-Europe has more or less framed these values in their definition of the general practitioner family physician. And I think for a long time it has been considered that this was nice, people liked it, it was warm, and as long as people did not have other needs, why should we not accept it? In my lifetime, I think a fundamental publication came about in 1994, and that's coming to the effectiveness of healthcare, and that was this publication of Barbara Starfield, who in the Lancet compared a comparison of, I think, 11 countries in terms of their ranking of primary care. The lower the number, the more primary care in their system. The UK, Denmark, the Netherlands, the countries with, at that time, the strongest primary care orientation, and ranked them according to the amount of money spent on achieving a certain health outcome. The more health for every dollar, euro, pound, or whatever invested. And there's a very strong relation in that publication. The more primary care, the better health outcomes in terms of cost effectiveness. Since 1994, there has been an overwhelming amount of literature to support this and to report that, yes, more primary care, better health outcomes, better life expectancy, better markers of population health, birth weight, early detection of important diseases, life expectancy. And in fact, that has changed. More the focus of health policy and the focus of health care. And interesting, this was a publication of a one-off in around about 1990. Interestingly is that that was not restricted to a certain period of time where you would expect other countries moving later with their health outcomes. No, the more primary care, the bigger the gap with the countries with less primary care, in fact, has become. So it was a very consistent factor. And as I said, this has influenced health policy. 3 years ago, the WHO reconfirmed its commitment to primary care and stated that it is necessary to train more family physicians, nurses, midwives, but not only train them, but also retain them in service and put people at the center of healthcare, have that led through primary care, strengthen primary care in order to strengthen health systems. Now, that is interesting, but the question that I would like to discuss with you is, in fact, what is causing it? The fact that Barbara Starfield concluded that primary care is essential is an important one, but what mechanisms are it that make primary care such an important contributor to effective health care? In fact, it was more or less addressed by the famous paper of Kurt Stenger, the editor of Annals of Family Medicine, the paper that he called The Paradox of Primary Care, in which he, based on an extensive literature review, concluded that if you look at disease-specific outcomes, you may conclude that specialist care is better than primary care, more effective, more contributing. Yet if you look at population health, primary care is a more decisive factor. Slightly put in other words, apparently poorer quality of individual care for individual diseases with similar or better functional health outcomes at lower costs with better equity and lower cost for population. And in fact, what Kurt Steiner was stating is that health is more than just taking care of diseases. But still behind it remains the question of what is it that makes primary care fulfill this role? And what mechanisms are behind it? What I've done and what I would like to share with you in the coming couple of slides is I've taken a reflective look at the research output of my department from 1985 till today, looking for indications or to inconsistencies in finding that can help us explain what that role of primary care is. It's a very unsystematic analysis, but as no one has ever done it, I think that's probably a good idea to start the ball rolling. So what does primary care add to make healthcare effective? And I've worked on the assumption that it is more important to live a long life functioning well than living with the best markers of outcome of disease-specific quality of care. And I've taken the research we've done, a program that was based on chronic diseases and comorbidity in primary care, general practice, but also from nursing homes, from occupational health setting, from care for homeless people, care for people in victims of family violence, people with learning disabilities, in short, the whole mix of what primary care brings together. And I've been looking for indications that could at least be considered as hypotheses of how primary care operates and how we can explain that it makes this contribution. It's long-term care of chronic patients with chronic disease, but also focusing on general practitioner doctors in difficult situations. We identified a couple: multimorbidity, medically unexplained symptoms, requests for euthanasia, where there might be a mismatch between what the professional and the patient are after. And I looked at a final set of research in communication skills. So what I would like to do is to give you a brief explanation of what the studies were, what the findings were, and what my interpretation of these findings were. And I would like to start with the research where I started my research in 1985 on chronic obstructive pulmonary disease. At that time, the disease hardly recognized in primary care as a disease that mattered. We did an intervention study. We found two things. First, it was a common disease in the primary care population, and we tried an intervention, and yes, there was response to an intervention, but that response was only marginal. And what we then did, and that engaged us in a program that took up more than 10 years of research, was, and I think here we have probably a first typical primary care orientation. We looked for what if we come to an earlier diagnosis at an earlier stage, intervention at an earlier stage in the development of COPD. And I think that's a pretty genuine way in which primary care looks at the addressing morbidity in the population, early detection and treatment rather than diagnosis and treatment as such. And what we did put us on the map in terms of research. We got a number of, I think, 7 or 8 PhDs from it. We got an impressive list of publications. In terms of research, we really made it with this study. But when I look back and see what it really brought, not so much to us or to research, but for patients, I think it is at least slightly complex and confusing what we found. What did we find? We screened the population of 10 general practices. And of course we found, when we looked for COPD, we found COPD, much more early signs, symptoms, people with early COPD than had been diagnosed by their general practitioner. That was what we were after, that's what we would expect. But at the same time, and here we come probably to typical primary care issue, in that exercise we found many, many more with signs and symptoms, but signs and symptoms that could not be matched into a formal diagnosis of COPD. Even a follow-up of 10 years, and we did a very strenuous 10-year follow-up. After 10 years, still, the signs and symptoms we picked up 10 years before were not matching the diagnostic criteria for COPD. I think that's a very straightforward way of saying that these people, whatever they had not COPD. So that's one interesting mismatch that we're encountering. Second, I thought was even more interesting. We had recruited a large number of people, put them on a regular review, invited them to volunteer to take part in that schedule of review. We got an immense participation, hardly any dropout. After some time, when we were identifying patterns of illness, we were recruiting people for interventions. And we thought, well, now you've taken part in our review for such a long time. Thank you very much. And it's really great that people took days off to come to the practice to be assessed. Their participation was very high. We were very glad to say now we can offer you treatment. And what was the interesting response? Quite a number of people. And the intervention we offered was inhaled corticosteroids. A dominating response of these patients who are very compliant in the diagnostic phase. Thank you, but no thank you. Well, that's at least interesting when you are dealing with patients who want to help and get early treatment in their disease. And the third part was at least as intriguing. With the many trials we did in this, our conclusion was that early intervention did hardly better than the marginal effects we found in the first study. Yet when we looked at the whole program, including this whole 10-year screening follow-up, the whole program was cost-effective. So we have a cost-effective intervention, but the drug that's at the core of it is not effective. I thought that were three issues, quite interesting. All the papers we published, no editor, no reviewer ever asked these questions. Now, what mechanisms or determinants can we postulate from these factors in terms of effectiveness? I think there are a couple. Focus on early detection, early diagnosis is probably one. But you can only, in an effective way, handle early detection when the intervention you do, diagnostic, therapeutic, selective. Had we been treating all these people with the minimal signs and symptoms, we would probably have not only over-treated the population, but we had over-costed the healthcare system. So early detection only matches well when it's done in an otherwise setting of selective intervention with wait-and-see or masterly inactivity approach. And the mismatch between what we as physicians were thinking we were going to offer patients and what patients were actually expecting from us is highlighting, I think, that patients' agendas are different from doctors' agendas. Now, to go into that, we got an interesting angle of another study we did. This was a study of depression, other patients, other diseases, similar findings. The study was aiming at understanding the nature of depression, that in the psychiatric literature is described as a recurrent disease, and the longer it takes, the more recurrences and the more difficult to treat. We followed up people for 10 years after their first life episode of depression. And what we found was that the recurrency rate as such was not as high as expected. But at the same time, we discovered that still, people who had this life experience of being depressed, that lifetime experience had a marked impact on them as persons. It was generally seen and reported by patients as something they wanted to have once and never again. And here came a discussion on how can we best help you in that, and what would be the role of medication. And again, there was a very strong voice from patients, not all, but a strong voice of patients. No medication. I would prefer my health problem to learn how to cope with it, and I don't want medication that may take away the symptom, that may mask the event I'm living through. Learning rather than treatment appear to be a patient's agenda. And that, if we then come back to the COPD study, that might be also the case for patients with COPD. Why are they so keen to understand what they have, what their symptoms mean, and then not necessarily opt for medication? Well, probably they want to learn what it tells them, how they can, other than through medication, change and influence their own health status. Quite a different agenda from what the typical medical agenda would be. A bit more on that agenda from another study. About the same time, this was a study on the management of asthma. And this came at a time that for asthma, proactive treatment was promoted through the prevailing guidelines, also the guideline of the Dutch College at the time, that GPs should be proactive in approaching patients. Patients should be seen on regular times in the year, assessed for their medication, assessed for their health status. And we tested this state-of-the-art management according to guidelines with self-management, in which we educated patients and offered them the possibility of treating their disease themselves. Now, this was a very classical randomized controlled trial. We had used, in particular, very disease-specific outcomes: exacerbations, use of medication, referrals, hospitalization. At the end of the 2-year trial, there were no essential differences between patient self-management and GP management. You could argue whether it's patients who treat themselves as good as their doctor would, or maybe GPs are able to treat patients as good as patients could treat themselves. But the interesting outcome we found was on an outcome that we had not defined as the primary outcome, but which might, from a societal perspective, be at least as important as the clinical outcome: the number of days people were off work. And asthma, as you know, is of course a disease of young adolescent people, adults and adolescents, particularly people in the working age, during working age. So with a substantial impact on their ability to work. And what we found was that patients under self-management, patients who were responsible for their own disease, had substantially fewer days off work. And that may give an additional cue, I think, to why people are so interested in learning to cope with their own disease, because it can help them to fulfill the functions they are willing to undertake in their life. And what we discovered from other studies on with chronic diseases as well, is how immensely important, in the patient's perspective, participation in life, including participation in work, is, and how the management of their disease is influenced by it. So if we add that to the points I had just made, we are much more looking at a learning than a treating approach to disease. Something that is probably very difficult to do in a once-off. Most of our studies came from longitudinal analysis of patient trends, in which care over time, rather than the once-off episodic outcome, was important. In other words, we come to the issue of continuity of care. And changing patients' values and patients' perceptions, rather than changing their disease markers, is something that would require a visit and revisit of their health status over time. And functioning, self-development, autonomy appear themes that are much more at the core of management than the disease control. And that focuses on another paradigm. Okay, let's move to another set of studies we did. Studies which you could describe as general practitioners. These were mainly general practitioners coping with difficult situations where the agreement of the agenda of the patient and the doctor were not necessarily harmonious, which will probably be often the case when people have more than one chronic disease. How do you cope with that? How do you deal with that? Do you add up all the protocols that are available and add up all the medication that can be provided and the diet measures? Or do we focus on patients' preferences in this? Dealing with medically unexplained symptoms, where quite correctly the GP may conclude that the patient doesn't suffer from a threatening organic disease, but that is not automatically meaning that that's also the patient's view. And in the Netherlands we have the law on euthanasia. General practice plays a major role in it. One of the criteria in euthanasia is the understanding that the patient is under unbearable suffering. And unbearable, of course, is a very intersubjective term. And it can be very difficult in a terminal care trajectory when patient and GP would not see eye to eye on whether the suffering is actually unbearable, can still be relieved by easily available interventions. So differences in perspective and differences that hamper adequate treatment. And what we had is with three completely different studies, different GPs, different researchers. In all three, there was a qualitative analysis of GPs, focus groups on how do you cope with these sort of situations. For me, as an aside, one of the great examples of how important it is that we mix up quantitative and qualitative research to come to an understanding of what we are actually doing. But now, how do the GPs cope, and which mechanisms may this present to the effectiveness of care? In all three studies, it became obvious that whatever the problem GPs were encountering, whenever there was this mismatch of lack of understanding or lack of agreement between GP and patient, the first and most important thing they did was invest into the working relation with the patient. Whatever they did was keep the relationship going. Look for opportunities, and quite often there are opportunities later on to come to a good choice on how to cope with the multiple diseases. A new opportunity of explaining to a patient that the signs and symptoms are not the markers of a threatening disease, but part of their life. And in an ongoing relation, it is possible to come to a new assessment of how bearable or unbearable suffering is. So GPs invested into the relation, kept the relation going, and all other aspects of their performance were secondary to that, including whatever prevailing guidelines might tell them to do. Okay, my last example is an example of a study currently underway on assessing GPs, but particularly GP registrars, competence in communication. Appropriate communication skills have been, I think, from the very start of residency training in general practice, a key issue. And at the same time, there is a growing awareness that registrars, but also experienced general practitioners, don't show very good quality of communication skills. And either they're all stupid, or maybe there's something else behind it. What we did, we have a beautiful library of the Dutch Institute of Primary Care, the Nijmegen Institute, a video library of all sorts of consultations from general practice, also from other health professionals, but from general practice is the largest. And we analyzed a random sample of consultations for a new health problem. And again, we confirmed that their performance, we used a prevailing assessment tool, was pretty low. And before we would judge GPs on it, an interesting question would be, how sensitive are such guidelines to the fact that GPs operate in a continuity of care setting? And although the health problem may be new, the patient has been with the GP many times. If you know the patient, you probably will not ask questions that are ordered by a protocol of communication that you should ask. And we call that context. And we looked at issues that were related to the context of the patient and to the knowledge the GP had of that specific context, which would, on the one hand, say there are issues you will never ask because you already know. There are issues you will never go into because you know it's not something this patient would appreciate. And there might be issues that you would like to highlight, even if it's completely irrelevant to the health problem that is presented at that particular moment. And when we modified the whole assessment tool for these factors, we discovered that there was a much higher concordance between expected and desired performance or competence. So again, what we see here is that general practitioners don't rule on each patient all the time the same, but are highly sensitive to the personal context of patients. So, as a last point, the personal relation and the individual context come forward as important factors that play a role in the day-to-day work of primary care. So, in fact, we could say, well, what is primary care? It's finding answers to questions of patients. And as quite often, most of these questions don't have an answer. You have to find an answer. There's no pre-coded answer. And probably what we need is research, but also teaching and training that is much more sensitive to this to these issues if we want to innovate or renew practice. And multimorbidity or patients' expectations, preferences are probably playing an important role. And what we come here, and I think that's where we see the difference of primary care with particularly organ-specific specialist care, the difference between responsive to supply-driven. We are living in a healthcare system that is procedure-centered, performance-oriented, and analytical for the possibility of your supply, focusing on interventions, on diseases, with a very strong a priori definition of what that would mean in terms of quality, particularly instrumental quality. And we should contrast that where in responsiveness we have to deal with person-centeredness. Two people with the same disease may differ in their need for response because they are different individuals, and that is related to their context. It's much more an integrative rather than an analytical approach, and it's focused not so much in intervening but on understanding, with patient empowerment as an important feature. And although that is something patients probably need, it's also very difficult to pre-code how this would translate into interventions that are relevant or not relevant. There's a high degree of professionalism involved, and not so much of prescribed guidelines or prescribed quality outcomes, with interpersonal quality as the key factor. And I think that is where we need that new approach of the academy. Not so much on interventions, but as we phrased it at the Wonca conference on why do we need research, why do we need teaching, it is because we need to improve care of patients. And care of patients brings us directly into the direct environment in which patients are cared for. And that's the importance of practice-based research networks or practice-based teaching networks. And the model that I think we need goes a bit like this. We all grew up in the traditional model that we have research to lead efficient practice. That there is research of new knowledge, and we feed that new knowledge to a practice that is hungry for new information because it's completely ignorant of what to do. And how much researchers may think that this is the reality in which they live, it's, I think, nothing is more beside the truth. While on the one hand we create knowledge, on the other hand we have people in practice, and these people have an immensely empirical wisdom. And there are two ships passing in the dark, and unless we are able to connect and take that empirical wisdom, and I think most of the issues I've highlighted in my analysis belong to that field of empirical wisdom, and take that into account and put that into a context in which healthcare is provided, linked to a community, linked to a context of patients that come, and based on not items of service but continuity over time. And from that basis, rather than from the disease-specific basis, try to answer the most important questions that we're faced with. And in rounding up, this is, I think, exactly what makes the specialty of primary care into the specialty. A specialty that's there for all health problems, in all stages, in all patients, all groups, but the in-depth part of that specialty is not so much in the health problem, but is in the direction healthcare takes, directed on family, person, living environment, in reference to social values, and based on the core principles of direct access and working in time, working in a relation in time based on trust and responsibility over time for patients. I'll better skip this. So, in the end, now what is the, in my view, the important transaction that we have to make? With more care in the community and more care focused on the direct contact with patients, hospitals are in all probability not the prime place for treatment. But it doesn't mean that we can do without the expertise that is available in the hospital setting. So the big issue for primary care, I think, is to help that expertise break out of the hospital wall and give it a network of a relation of trust, continuity of care, focus on the population under care and their specific needs, and the individual needs of patients. And I think that is where effectiveness of healthcare, how effectiveness of healthcare is improved by the role of primary care that has this responsibility and responsiveness to needs, provides that continuity, that person-centeredness, that fosters not so much the treatment of diseases, but the self-reliance and autonomy of patients, with a focus on early but very selective interventions. And in terms of further development, we need to link the variety of people, the variety of populations and communities that we have. And a commitment that comes with it is important. I think it may look like old-fashioned value. And probably it is back to the future. But if the values are there, it's probably the way we have to go. And if there is a need for more continuity, we must look at possibilities of fostering continuity of care throughout the various phases of our healthcare system, because that is adding to patients' health. Thank you very much.
Mentioning the difference between GPs and specialist treatment, that there's more emphasis on the self-empowerment, being aware of the illness, taking into account the personal relationship. Would you then also advocate, which is now the current discussion, whether we should have GPs should more use nurse practitioners, people who spend more time with the patient actually are sometimes more aware of their contact than we are as GPs. There's a big debate whether we should do that, and it's in different countries. I know it is in the Netherlands, it's in the States, but it's here in Australia as well. I think the talk pretty much advocates the use of nurse practitioner or whatever you call them. Do you agree?
Well, I think I think for ourselves in primary care should realize that continuity of care is much more than just seeing the same provider over time. It has to do with consistency of knowledge, consistency of operating, and of course we cannot go back to a system where every doctor is responsible 24 hours a day, 7 days a week. That is an illusion. But when continuity is an important issue, we must find new ways to do it. And I think teamwork where nurses, but also receptionists in the Netherlands, receptionists play an important role as the front office of the practice and the accessibility, where there's a lot of understanding of why this person comes today. So we must invest much more in this team shared approach towards continuity rather than make it the individual act of an individual provider. And it's sharing the value thereafter is probably an important mechanism of bringing a team into the community, the continuity approach. And then I think, like you say, nurses have a special role to play. There are things doctors can do better, there are a lot of things nurses can do better. And we must build on that capacity rather than bring it into some sort of a competition.
Just wondering the connection between these factors, like having a personal relationship and self-advocacy. I'm not sure I understand how they actually relate to a better outcome. I mean, is it just that in a lot of chronic conditions, treatment isn't all that effective? So that you get a better outcome by making sure the patient doesn't enter into treatment that won't do a lot of good and may do some harm.
Mm-hmm. Yeah, well, I don't think I know the answer to your question of what exactly makes that come true. I think it has a lot has to do with perspectives. We know that, for example, that study on the management of asthma. In clinical terms, the group that was just doing what the doctor was ordering, was in clinical terms exactly as well off as the people who treated their own asthma. Yet in their behavior, in their functioning, there was a big difference. Now, what causes that? Is that related to, it's not the disease, it's probably the context in which that disease is treated. And I think a lot of that is true for other aspects as well. People who feel that they are in charge of their condition, even if the condition is not that much different from someone else, are able to do a lot more, and that's what we call health. I think it has to do with issues like that. Accessibility, availability of care is important. The feeling that you have access to care often means that you don't use it. One of the best ways of making people very uncertain is to try to restrict access to care.
there first and then Rosemary. Yep. No,
Sorry.
you go first. Yep.
Sort of along the lines of the access within Australia and the accreditation system. I can't remember exactly what the Netherlands system is, but I know it's very good. Do you think without that kind of system in Australia, you could get that kind of continuity and effectiveness and access that would be needed to?
Yeah, I'm of course my research is grounded in a system where everyone is listed with a practice and where 96% of all health problems that need professional intervention are treated in that practice. And I think that is helpful. But I think it is a way to achieve that. The conclusion, I think, it's important that you have this continuity. So what I think you should do in Australia to improve the health of your population is to at least create as many incentives as possible to have continuity. We know that in Flanders, in Belgium, where people say, well, people are more or less identical to Dutch people, but they don't have this system of continuity. Yet a lot of people, de facto, make use of the same doctor all the time. So it's not just a rules and regulations issue. It's also, and probably that's a much better way of achieving it, a way of, when someone trusts you, why would that person look for another doctor? And if that person doesn't trust you, why should that person come back to you? I think that is what, for me, would be much more the answer to the question.
I'm interested in your comment about continuity of care in context and the role that primary care can play in terms of meeting the patient's needs sort of over a period of time. And I think it's true. I think that primary care is very good at doing that. But I don't think it's unique to primary care, so that if you consider some specialist care, for example, diabetologists who look after particular patients with diabetes for long periods of time, decades, and not only provide excellent care, but also do understand about context and continuity. And I've seen also good examples of it in some cancers, not all, but some. And so I wonder whether what's perhaps differentiates primary care from specialist care is getting back to your original point about sort of comorbidities and multimorbidities, and is there opportunity to do that? But it doesn't seem to me to be such a differentiating factor, and I wonder if it's about the coordination of the multiple sort of morbidities and multiple issues and diseases that is perhaps something closer to the unique niche that primary care plays.
Well, I think it is in bringing a lot of things together. It's not a single difference that determines it. And I would think if continuity, person-centeredness is helpful because primary care provides, then by that same reason should be important issues for how a surgeon, a neurologist, a diabetologist approaches patients. The problem that I see with some of the diabetes, you see it to take care of the whole patient, but it remains diabetes and the whole patient. And all these patients have in their lifetime a whole lot of other issues that cannot necessarily be well covered in a diabetes setting. So therefore I think we need this interaction, primary care, secondary care, to make sure that overall there's a framework and accessibility to appropriate health care. We see a big problem at this moment in the Netherlands in care after patients have been treated for cancer. For all sorts of reasons, oncologists keep on following up patients. And these patients like that. that's a trust doctor, that treated them, that treated them in a very difficult situation. Yet the oncology outpatient departments are overwhelmed by signs and symptoms of everyday life. And in their context, these signs and symptoms are reduced to the simple question, is it cancer, is it not? And I think living with cancer is more than just the question, is my cancer back or not? So I think, again, take that, integrate in that respect, primary care, secondary care. Make sure that primary care does a lot of follow-up of people who are living with cancer, and make sure that at critical moments, the oncologist is part of the team, the diabetologist is part of the team, both in the frame of continuity of care and person-centeredness. That is, I think, where we have to go. And that's probably something that primary care must structure for healthcare. Yeah.
With primary care and oncologists who actually don't want to see
Yeah.
patients who they don't need to see because it means they can't see a lot of the new patients.
Yeah. Well, of course, we train oncologists to treat cancer, and that's a great value for the population. So they should be free to do the things they're good at, but they should do it in a context of continuity and with direct interaction between primary care and secondary care.
It's kind of related to that. How do you ensure access and continuity without facilitating over-servicing?
Well, that's, I think, the outcome of our COPD study. How do we cope with a lot of people with signs, symptoms, that respiratory signs, symptoms, pick up the few who have COPD and don't treat the ones who don't have COPD. How do dental practitioners apply a wait and see policy? We do it every day, and we do as if that's the most simple thing to do. And it's probably the most complex intervention we apply. It's probably much more complex than having someone on life support in an intensive care unit. So, if we don't advocate for that this is a vital issue, of course, everything I've said doesn't take away that there will be good and bad primary care. There's good and bad person-centeredness, continuity. So we must go into that area, and what exactly makes wait and see or masterly inactivity, or whatever you like to call it, effective, and what are the pitfalls, is something we have to explore in depth, because it's a key factor in the management of the whole healthcare system. And it at least one clue to it is seeing patients back. You can't do this when you just today see a patient. When you just today see a patient, you will maximize, because you don't want to miss out on important issues. The possibility of say, well, okay, you can come back tomorrow, and if I'm not there, my colleague knows, it's in the notes, and you're welcome to come, and I can give you a couple of signs that would be relevant to look at, and don't hesitate to contact. It's that sort of thing that is at the core of the wait and see. Continuity care is a key factor in wait and see policy.
One of the things that you continually alluded to that I'm interested in exploring is that health is that access to healthcare is only a very small factor in what contributes to health. And I don't think anyone's going to make very strong arguments that primary healthcare providers are particularly good at delivering on the social determinants of health or whatever you want to call them. But it is clear, I think, that people's education, their self-esteem, what goes on in terms of housing and transport and the air they breathe and the food they eat also contribute to their ability to manage these sorts of things. So I wonder if you're going to look at incorporating those factors into the sorts of analyses that you do. And in particular, I'm interested in whether or not countries that do better in primary care also do better in public health.
Well, I think that is absolutely correct point. What I think one of the big missing issues in healthcare, the lack of primary care, but also the fact that public health has disappeared from the whole healthcare system.
I think one thing that's fascinating to me is that even someone who's very sick, someone with multiple chronic conditions, spends only a minute part of their life within the context of the healthcare system.
Yeah. Most of the people, most of the time, most of the health problems are at home. But if we want to prevent or support, we have to be there. I think an important factor to make health more effective, but that was not part of studies I had access to, is linking social welfare much better to healthcare, because so many questions, problems are not so much disease, even if they are related to physical disability. You cannot solve with medical intervention, but with social intervention. So I'm wholeheartedly supporting your point, but I don't have any. It did not come from any analysis of our research at this moment.